A very good morning to one and all. Today in this session, we'll be talking about maxillary sinus and its implication. The topics that I'll be covering today are the surgical anatomy, the infection associated with maxillary sinus, that is acute and chronic sinusitis, Oro-antral fistula, its etiology, clinical features, management, and surgical approach to sinus, that is the Caldwell-Luc surgery. And in the last, in brief regarding FES, that is functional endoscopic sinus surgery. Let's move on to the surgical anatomy of maxillary sinus. Maxillary sinus was first described by Nathaniel Highmore, hence it is also termed as antrum of Highmore. It is largest paranasal sinuses that are spared and present on either side of the maxilla. It is pyramidal in shape with its base towards the nose, that is the lateral wall of the nose, and apex towards the zygomatic bone. It has four walls. The superior wall is formed by the floor of the orbit, whereas the inferior wall is formed by the hard palate and the alveolus. The anterior wall is formed by the facial surface of the maxilla, and the posterior wall is separated from the infratemporal fossa and pterygomaxillary fissure. The approximate dimension of maxillary sinus is around 3.5 cm anterior-posteriorly, 3.2 cm in height, and 2.5 cm in width. Its volume is around 15 to 30 ml. Its blood supply is basically derived from the facial artery, maxillary artery, infratemporal artery, and greater palatine artery. All these vessels pierces the bone and enter into the maxillary sinus and supply the sinus lining. The veins accompany the maxillary sinus and they drain into the facial vein, which eventually drain into the pterygomaxillary plexus of vein. The nerve supply to the maxillary sinus is basically from the superior dental nerve, that is its anterior, middle and posterior branch, and greater palatine nerve. Let's move on to the functions of maxillary sinus. Maxillary sinus provides resonance to your voice, that is, it gives a specific characteristics to your voice. It increases the surface area, thus making the skull lighter. At the same time, maxillary sinus moisten and warm the inspired air. Along with that, they remove all kind of debris and microorganisms from the inspired air. These maxillary sinus are present in front of the forebrain and the olfactory region. Thus, they provide an air cushion or a padding effect to the vital structures and preserve them. Let's move on to the infections of maxillary sinus. Infection, itis, maxillary sinusitis. The word itis means inflammation. It is nothing but inflammation of the lining of the maxillary sinus. Odontogenic sinusitis is termed nothing but inflammation of the mucosa of the paranasal sinuses. Why odontogenic? Odontogenic is mainly because these infections can arise because of tooth pathologies like periapical infection. Now, if all the sinuses are involved, like all the paranasal sinuses are involved or inflamed, then it is termed as pansinusitis. When only maxillary sinus is inflamed and involved, it is termed as maxillary sinusitis. What are the etiology of maxillary sinusitis? It could be because of infection. That is, a carious tooth can result into a periapical infection. So the tooth root apices of posterior maxillary teeth, that is the premolars and molars, are very close to the lining of the maxillary sinus. So any kind of infection can move from these tooth into the sinus can result in infection of maxillary sinus. Any kind of pathology, cyst or tumor associated can result in maxillary sinusitis. Trauma to the facial region can cause breach in the continuity of the maxillary sinus. More commonly in the trauma of the anterior wall of the maxilla causes a communication between the oral cavity and the maxilla. Since oral cavity contains a number of microorganisms, due to which the sinus can get infected and result in maxillary sinusitis. Maxillary sinusitis can also be because of an oro-antral communication or a fistula. It can also arise because of a displaced tooth or a root into the maxillary sinus. A displaced tooth acts as a foreign body and causes an antigen-antibody reaction resulting in inflammation of the maxillary sinus and eventually causing sinusitis. Let's move on to the clinical signs and symptoms of acute and chronic maxillary sinusitis. As the name suggests, acute maxillary sinusitis is because of an acute infection. So basically, patients will give you symptoms like severe headache, pain in the maxillary teeth radiating to the cheek, nasal obstruction, foul smelling discharge. There will be tenderness over the area of the cheek. because of pain and swelling, there could also be anesthesia because the infection is trying to compress the infraorbital nerve that supply the anterior part of the cheek. There could be mild swelling, oro-antral or communication can be present, and phytororis can be present. Let's move on to the signs and symptoms of chronic maxillary sinusitis. As the name suggests, it is chronic, that is, it is because of a long-standing, slow-grade infection. Here, the signs and symptoms will be similar to acute maxillary sinusitis. Along with that, patient will also complain of recurrent mucopurulent pus discharge. Post-nasal drip, there will be a frank oro-antral fistula, an epithelialized oro-antral fistula, and a polypoidal mass associated with it. Now, how do you confirm your clinical diagnosis? With the help of radiograph. To examine the maxillary sinus, a 15 degrees of occipito-mental projection is very important. Now, this projection is also called as PA Waters view. In this, you can see the maxillary sinus very clearly. In case of a normal patient, the maxillary sinus area look like in radio-opacity. As you can see in this picture, on the left side, radiolucency is there, that is the sinus is normal. Whereas on the right side, there is radio-opaque. Okay, here you will see a specific fluid level. What I mean by fluid level is that in case of maxillary sinusitis, if there is accumulation of pus, you will see a layer of air above it, then a thick layer of radio-opaque line, and then a radio-dense area below it. That is, air fluid level is well predicted in case of PA Waters view, as you can appreciate in this picture. Now, let's move on to the management of maxillary sinusitis. Now, acute maxillary sinusitis can be treated by advising the patient to have bed rest, have lots of fluid, accompanied with antibiotics like a broad spectrum antibiotic, for example, amoxicillin. Depending upon the age of the patient, you can give around 250 to 500 milligram 3 times a day. You could also give macrolides like azithromycin, roughly around 250 to 500 milligram. Now, these microbial antibiotics can be accompanied with nasal decongestion like xylometazoline hydrochloride. Now, these nasal decongestion, they not only decrease the thickness of the lining, but they also decrease the secretion, and they decrease the obstruction and provide easy drainage. You can accompany or couple this antimicrobial with decongestion with microlytic agent. Microlytic agent can be normal steam inhalation or steam inhalation aided with tincture benzoin. Now, these steam inhalation, they not only decrease the amount or the viscosity of the secretion, but they also make the patent, that is the ostium patent. They shrink the lining so that the ostium become patent and the discharge is facilitated. Along with that, it also creates a blanket of a septic area, sterilized area, so that the microorganisms do not grow. You can also give this patient non-steroidal anti-inflammatory analgesic like ibuprofen or paracetamol. Paracetamol, if you're giving, it should be around 500 milligram 3 times a day. And if you're giving ibuprofen, it is 400 milligram 3 times a day. Now, let's move on to the management of chronic maxillary sinusitis. Now, chronic maxillary sinusitis, you need to eradicate the cause because they will not respond to medical treatment unless the cause is removed. If the cause is because of a periapical infection, then you need to treat the periapical infection first. If it is because of a root that is into the maxillary sinus, you need to remove that root to decrease the maxillary sinusitis. Okay? To facilitate the drainage in case of chronic maxillary sinusitis, you could do a surgical procedure which is called as intranasal androstomy procedure, wherein you take a cotton pallet on which you will apply local anesthetic agent and place it in the floor of the nose near the inferior turbinate. Then you'll remove this, you insert a trocar into the inferior turbinate through pierce the medial wall of the maxillary sinus. Once you have pierced the medial wall of the maxillary sinus, with the help of suction, you can suck all the pus inside the sinus. As we know that the floor of the maxillary sinus is much below than the floor of the nose. The discharge does not take place depending upon the gravity. You need to do an active discharge. You need to drain it through a suction pump. Now let's move on to the other condition of maxillary sinus, that is oro-antral communication and fistula. What exactly is an oro-antral communication? An oro-antral communication is an unnatural communication between the oral cavity and the maxillary sinus. Then what is a fistula? The fistula is nothing but an epithelialized, pathological, unnatural communication between the two cavities. So a communication is not epithelialized, but a fistula is epithelialized. What are the etiologies of this oro-antral communication fistula? It can be because of a traumatic extraction. While you are extracting third molars, maxillary third molars, or second molar, first molar, the root apices are very close to the floor of the sinus. Sometimes if you added more force, the sinus lining can be ruptured and can cause an oro-antral communication. It could arise because of periapical infection, because of injudicious use of instrument. Is there a periapical granuloma? You're trying to curettage that area. While curettaging, you have to be very careful that you not breach the continuity of the maxillary sinus. Because of the trauma, there could be an oro-antral communication. Because of infected implant in the maxillary area, posterior region can result in oro-antral communication. In case of cysts and tumors, or because of chronic osteomyelitis. Now, what are the signs and symptoms of communication in a fistula? In case of a fresh oro-antral communication, you need to remember 5 E's. That is, there will be escape of fluid. That is, when the patient tries to gargle or rinse, the fluid from the mouth can go into the nose. There will be escape of air. When the patient tries to blow, when the mouth closes, the air can escape into the nose. There will be unilateral epistaxis on the affected side. It is because of the blood that is accumulated in the maxillary sinus is draining through the ostium into the nose. There will be enhanced column of the air. As I mentioned earlier, maxillary sinus play a very important role in maintaining the resonance of your voice. So, if there is an oro-antral communication, the voice will be altered. And there is an extreme excruciating pain. Now let's move on to the signs and symptoms to oro-antral fistula. You need to remember 5 P's. Now, in case of a communication where the pain was excruciating, once that communication is epithelialized, the pain is comparatively less. It is less because a proper pathway is formed for the drainage of the pus. There will be persistent purulent mucopurulent discharge. Posterior nasal discharge will be present. There will be generalized systemic toxic condition. The patient will be weak. There will be fever, malaise, nausea, anorexia, cacosmia. There is popping out of the antral polyp is visible in case of oro-antral fistula. Now, how does an oro-antral communication develop into a fistula? So, whenever you do an extraction, you remove a root piece or because of an infected implant. The periapical area, since it is very close to the nasal floor, very close to the maxillary sinus lining, the sinus lining is bridged. So, when the sinus lining is bridged, a clot is formed. Normally, the clot will organize and the opening is closed automatically. But in case of infection or you are trying to poke your instrument inside and you dislodge the clot, or if the patient has a severe episode of sneezing because of which the clot is dislodged, or the patient is spitting continuously because of which the clot is dislodged. So these are conditions that I'm saying that the clot might get infected or either it is dislodged. Once this happens, the communication becomes patent and eventually it epithelializes and result in formation of an established fistula. Now, how do you confirm that it is a fistula? In case the fistula is large, you can appreciate on intraoral examination, that is during your clinical examination. But if it is very small, you have to do 2 tests. One is the nose blowing test, wherein you ask the patient to close the nostril and to keep your mouth open and try to blow the nostril. Because of the negative pressure in the nose, a whistle sound is here since the air is passing from the nose into the mouth. This will confirm your diagnosis that an oro-antral communication or a fistula is present. Or what you could do is you could take a wisp of cotton and hold it just below the opening. So the wisp of cotton is deflected. That means there is passage of air from the nose into the oral cavity. These are the 2 tests that will help you to identify oro-antral communication and fistula. Now let's move on to the treatment of oro-antral communication and fistula. In case of an early treatment, when the patient has come early to you within 48 or 24 hours, what do? Is you try to compress the buccal and cortical plate after the extraction and you try to suture it. Give an antibiotic prophylaxis, nasal decongestion and analgesic. In case you're not able to suture it, you give a releasing incision into the buccal vestibule, reflect the mucosa, do periosteal stripping, and then try to close it. So primary closure is very important to eliminate oro-antral communication. In case of delayed closure, what you can do? There are a number of surgical procedures that are available in case of delayed cases, wherein you can use a buccal advancement flap. There is also a modification of this buccal advancement flap called as Rehrmann's flap. You could use a palatal rotation flap or a combination of both buccal and palatal rotation flap. In case of a buccal advancement flap, what you do is that whenever there is a patent oro-antral fistula, you need to cut out the fistulous tract first. So you will do a circular incision around the fistulous tract in such a way that it is 3 to 4 mm away from the margin. Now this is because the soft tissue opening is always smaller than the bony defect. That's the reason why you need to cut out or freshen up the margin for around 3 to 4 cm. Remove the entire fistulous tract. If there is any kind of nasal polyp attached to it or any kind of inflammation, you need to remove that. Once you have removed that, thoroughly clean the area. If you need to widen the fistula to inspect the sinus, widen the fistula and clean the sinus, control the bleeding. After that, you will give 2 divergent incisions from 15 number blade from either side of the opening, extending into the buccal vestibule. You should keep in mind that your base of the flap should always be wider. So your divergent incision is going to be diverging into the buccal circus. It is never parallel. Okay. So once you have given your incision, you will reflect the complete mucoperiosteal flap is reflected. Once the mucoperiosteal flap is reflected, you will try to pull this buccal flap and over the fistula and suture it to the palatal region, as you can see in the photograph. You need to keep in mind sometimes the mobility is less. So what do? You do periosteal scoring. What do you mean by periosteal scoring? In this, you will try to separate the periosteum from the muscle in those places where you find more adhesion or where the flap is not able to move. So in that case, you will do periosteal slipping. But drawback of these flap is that there is decrease in the buccal vestibular depth when you use this flap. This is one of the drawback of it. And it cannot be used in case of a wider defect. It can be used in case of a smaller defect. Now to overcome this, Ashley has put forward a palatal rotation flap. As we are aware of that, the greater palatine artery arises from the greater palatine foramen and it moves from the second molar anteriorly into the hard palate, just in between the midline and the attached gingiva of the palate. So this portion of the hard palate is required to move. So we raised a complete mucoperiosteal flap based on this greater palatine artery and try to rotate it and cover the fistula, as you can see in the diagram. Here similarly, you will remove the fistulous tract first, then you will raise the flap. Okay, the lateral margin of the flap should be around 5 mm away from the attached gingiva. Okay, it moves depending upon the amount of depending upon the fistula and the amount of rotation, the length can be decided. Okay, and then you raise a complete mucoperiosteal flap, you rotate it over the fistula and suture it towards the buccal side. Now the advantage of this flap is that it is thick compared to the buccal flap. It have a good amount of rotation, and because of the thickness and highly vascularity because of the greater palatine artery. But one of the drawback is that it starts to kink when you try to rotate it. Obviously, when you're trying to rotate something, there will be kinking. So to avoid this kinking, Kruger gave a modification wherein a V-shaped tissue is removed where the flap is getting kinked. Now when you're removing this V-shaped tissue, you should be careful that you're not very close to the pedicle. Otherwise, you will affect the vascularity of it. So you remove that V-shaped kink and then suture it, the flap, to the buccal side. Now to overcome the disadvantages of both the buccal as well as the palatal rotation flap, we have a combination of buccal and palatal flap. These are used in case of a larger fistula or in case where already a fistula closure attempt has been made and it has been failed. So in that case, we try to use both the palatal and buccal flap to close the fistula. It provides a double layer watertight closure. Let's move on to another procedure that is termed as intranasal antrostomy. Now this procedure is done after you have closed the fistula and when you have to drain the maxillary sinus, or whenever there is presence of any kind of root piece or a tooth in the maxillary sinus. So this procedure can be used coupled with Caldwell-Luc procedure. So in this intranasal osteotomy, you will use a trocar inserted into the floor of the nose and pierce the medial wall of the maxillary sinus. Okay, you take a bone gouge, increase the diameter. Once you have increased the diameter, you will drain out or wash out all the pus that is coming out. Okay, from the nasal opening, you will insert an iodoform gauze and you will pack the oral or you will pack the sinus cavity. Now, as I said, this procedure is used in conjunction with Caldwell-Luc procedure. So in Caldwell-Luc procedure, you will have an already oral opening will be present. So you will insert this iodoform gauze from the nasal opening and try to remove it from the oral opening. You will tie a knot on the nose and then you will fill this gauze completely inside the sinus cavity. Okay. Now when you remove it, while you are removing the gauze, you can remove the root piece that is present in the maxillary sinus. This provides an atraumatic removal of the root piece because you're not using any kind of instrument. Because if you use an instrument, you're trying to cause injury to the maxillary sinus lining. So to avoid that, so this procedure is basically used in conjunction with Caldwell-Luc procedure. Let's move on to the Caldwell-Luc procedure. Now what are the indications? As I mentioned, it is used to remove any kind of foreign body from the maxillary sinus. It is used when there is a hyperplastic lining or a polypoidal lining of the maxillary sinus when you need to remove the maxillary sinus lining. In case of cyst of the maxillary sinus, malignant tumors of the maxillary sinus, in case of zygomatic complex fractures, where there is an oro-antral fistula in case of a chronic sinusitis. So what do you do in Caldwell-Luc surgery? In Caldwell-Luc surgery, the important anatomical landmark is your canine fossa. You enter the maxillary sinus through the canine fossa. Why? Because here the bone is very thin. Okay, so you will make a semilunar incision from the canine fossa and extend it towards the first molar region. You will raise a complete mucoperiosteal flap. After raising the complete mucoperiosteal flap, you will stabilize it with a retractor and protect the infraorbital nerve. Then you with a trocar will make a hole in the anterior wall of the maxilla through the canine fossa since it is very thin and try to enter into the maxillary sinus. If required, you can increase the opening of the maxillary sinus. It should be such that your index finger can go inside and you can clean the maxillary sinus. So once you have removed the bone, put your index finger inside. Inspect the maxillary sinus. Remove any kind of root piece that is present in the maxillary sinus. And then close it. One of the recent advancements in the field of maxillary sinus surgery is the use of functional endoscopic sinus surgery, wherein an endoscope is introduced into the nose, into the maxillary sinus to remove any kind of infection or the polypoidal mass or the maxillary sinus lining. Here this endoscope has a camera which could be visualized and have small attachment which could be used to remove the sinus lining. Thus I would like to conclude by saying that there is a common embryological origin of the paranasal sinus and the nasal cavity. They share a common physiological characteristics, that is the lining membrane, the disease and the inflammatory process. Along with that, there is a close approximation of maxillary sinus to the orbit, alveolar ridge and maxillary teeth. Thus, a clinician should have a thorough knowledge of the anatomy and embryology to come to a proper diagnosis and treat the maxillary sinus disease. Thank you.